Good evening, everyone, and perhaps good morning or good afternoon for anyone who's joining us from other areas of the world. And welcome so much. It's a pleasure to have you all with us for tonight's webinar, where we are welcoming Professor Allan Young, who's joining us from London, to speak to this topic, as you can see on the screen, the treatment of mood disorders, looking at what does the future hold. And so, before I do introduce Professor Young, I'm just going to give a very brief introduction to Mind Medicine Australia and to the work that we do. I'm sure there are many on here who've seen this before, but for those who are new to our work, and then I'll introduce Professor Young and hand it over, as I know that he's the person everyone's here to listen to, not here to listen to me. And so, just to begin, a brief disclaimer is a reminder that My Medicine Australia's focus is on the development and use of evidence-based psychedelic-assisted therapies, and that's within regulated healthcare systems. We don't encourage the use of psychedelic medicines outside of this context. We don't support the use of these substances in any way that's unlawful. Our presentations are intended for educational purposes only, and they don't constitute medical advice. Individuals, please do discuss your individual health needs with your healthcare provider. And just as a final note, these sessions are recorded and then will go up on our YouTube channel later on. So just to set a little bit of context, looking at the mental health situation that we have in Australia, at this point, research, like studies have shown 1 in 4 Australians with mental illness and as many as 1 in 6 in any one year that are treated with antidepressants. This is a really large increase over the last 15 years. And this includes 1 in 30 children, 1 in 4 older people. And as we know, there are sort of some side effects and things such as this that exist with some of these pharmacological treatments that we have. This comes with real costs. And obviously there are costs to society, but more importantly, really are costs to people's life and well-being. And something that we've seen with My Medicine Australia has been a slow process from decision makers in the mental health space to look at making changes. And so despite best efforts of clinicians, what we haven't seen up till now is significant changes in these numbers. And the elephant in the room, as we often say at My Medicine Australia, is a lack of innovation in treatments for mental illness, which is really what Professor Young is here to look at for today. And so on this slide, as you can see, it's just really looking at quite low incidences of remission rates that exist with mental health conditions such as depression or PTSD with some of the existing treatments and some of the side effects that do exist with some of the existing treatments that we have. And so a more of the same approach isn't going to solve the problem. And so this is to introduce Mind Medicine Australia. We are a charity or charity not-for-profit, and we exist to help alleviate suffering and suicides in Australia caused by mental illness. And our aim is through expanding the treatment options available to medical practitioners and their patients. And what we're looking to establish is safe and effective psychedelic-assisted treatments to treat a range of mental illnesses. Our primary focus up until this point is looking at psilocybin and MDMA, and then also ketamine as well, and supporting their introduction into the health system in a controlled way. And the indications of success that you can see these 3 listed here is that they eventually become an integral part of our mental health system, that they achieve high remission rates, that leads to substantial improvement in those mental health statistics that were outlined earlier, and really importantly, that they become accessible and affordable to all Australians who could need them. So this is something that our aim is to make it something that it's not just for wealthy people or not just for people in cities, but also through regions. And this is also obviously following the evidence base and the research as it progresses. So as mentioned, the primary focus, the 2 primary medicines that we've focused on so far is psilocybin. Particularly this has been looked at for depression, but there's also other indications that are being studied, and MDMA, which is also primarily being studied for PTSD up till now, but there are other indications again. These protocols use 2 to 3 dosing sessions with psychotherapeutic support around those, and they aim to lead to substantial improvement of symptoms and remission rather than just looking at managing symptoms. And so far from the research, what we've seen with these is they're very safe when in a medically controlled environment. So the way that My Medicine Australia goes about this is with four key strategic areas. The first is awareness and knowledge building. The second is our professional development program, which involves our certificate in psychedelic assisted therapies, which trains healthcare practitioners on delivering these therapies, as well as an introductory online program, which I'll speak about a little bit more about both of these in a little bit. We support research and also then supporting patient access. So these are the four areas that we work in. And to just give a very brief overview of some of the achievements that we've made in across these four areas. The first of them in terms of patient access, and this is perhaps one of the most, or perhaps the most significant achievement of My Medicine Australia over the 6 years since we started, was the advocacy for the successful rescheduling of MDMA and psilocybin in Australia, which made Australia the first country to do so. And then also securing access pathways for MDMA and psilocybin, which is to allow affordable access to pharmaceutical grade MDMA and psilocybin for within use within the regulatory scheme in Australia, and also the launching of a patient support fund in the early stages of these therapies before other traditional payers within the healthcare system are supporting funding for these treatments. This is an opportunity for private funding to support treatment and make it more affordable for those who could benefit from it. In terms of awareness and knowledge building, we ran the International Summit on Psychedelic Assisted Therapies that was in 2021, as well as other events such as this, our global webinar series, of which this is one of, and then we also have built a network of chapters around Australia. Our professional development program, we're up to 500 clinicians who've been trained through this over the last 4 years in our certificate in psychedelic assisted therapies. And then our fundamentals of psychedelic assisted therapies is an online 6-week course, which is at a more introductory level, giving that higher level introduction to people interested, whether they're clinicians or the general public, in learning more about this field. And then in terms of research, there was a $15 million grant from the Australian government that was secured through advocacy that Mind Medicine Australia did. It was the largest at the time government grant for psychedelic research in the world. We're the largest funder of research outside of government and pharmaceutical sectors, and also funded and facilitated a number of clinical trials and also a registry that's been set up to collect outcome data from clinical use of MDMA, psilocybin, and ketamine in the authorized prescriber program. So this slide just shows some of the headlines that we saw early last year when the rescheduling was announced for Australia. And this is just something that was highlighting that it was a world first, and when this change of regulations happened in a very unusual or unexpected turn of events, Australia became the first country in the world to do so. And as it says at the bottom, as a part of this, we have a heavy obligation to do this well and do it right and support safety as well as good outcomes in this program. And so, sorry, I jumped a slide there. Just to give a very brief overview of a couple of these key programs, our certificate in psychedelic assisted therapies is a 4-month program, as I mentioned, which provides upskilling for healthcare providers who are interested in entering this space. It's 4 months largely online with a 1 week in person, so that makes it accessible for people, even regardless of where you are in Australia or even internationally, to study online and then join just for that 1 week in person. And you can see a quote here from Professor David Nutt, who suggested that it really is one of the best courses of its kind in the world. It has an amazing faculty, Professor Nutt, who I just mentioned, and Dr. David Arizzo, both from Imperial College, as well as some of the other leaders in this space from the United Kingdom, Europe, and the United States. And just finally, the applications are closing just in a few days for our next cohort. This cohort begins in February next year. And so if there is anybody at all who's interested in getting trained, now's the time. If you go to cpat.mindmedicineaustralia.org, you'll find all the information there. And you can also connect with our team to have a chat with a member of our team or with myself for any more details. So if this is an area that you're interested in going into, please do go through there over the next couple of days to have a look and see if maybe this February intake is the right time for you to join and get trained. Our fundamentals, as I mentioned, is an introductory program. And so for those who are maybe not quite ready to do the longer training and a more in-depth training to learning how to deliver these therapies, this is 6 weeks. It's online. It's It's a self-paced program at the moment. So the 6 modules, you can view the recordings in your own time. And this is available at the URL here as well. So please do take a look at this if this is something that's interesting for you. Then just a couple of points here in terms of ways that you can help out. In addition to the training that was outlined here, you're more than welcome to reach out if you're interested in volunteering or helping us to fundraise or donate, and just keeping in touch. And also having conversations is always something in an area such as this, an emerging field of having conversations with those in your networks and communities about this area as you learn more about it. Helps to continue raising awareness and building understanding in this new field. So just as a couple of final slides, if you do feel called at all, please do donate. We really do appreciate any support that you're able to give. You have 2 options if you're interested in donating to Mind Medicine Australia. The first, which is outlined here, is into our patient support fund. 100% of funds in this go directly to subsidising patient treatment. So patients can be nominated by a psychiatrist who's delivering these treatments for an application to then receive an allocation from this fund. So please do support to help those who otherwise couldn't afford treatment to get access to it. Or you're welcome to donate into our general fund. And this can go to a number of different areas, including supporting accessibility, subsidizing some grants towards the training for those who may not be able to train, also potentially going towards research and other programs. So there's the link here at mindmedicineaustralia.org/donate. And then finally, this is just a listing of events that we have. We have a couple over summer that are in person. Tanya's speaking at a conference up in Byron Bay, as well as an event that's here in Melbourne in February, the community event, and you'll see a lot more great sessions in our webinar series, such as this for next year. So please do jump on our website to sign up for these. And so that is enough from me. I will stop sharing my screen now and introduce Professor Allan Young. Professor Young is a Scottish psychiatrist, even though he's joining us from London. And he is the chair of mood disorders, and he's the director of the Centre of Affective Disorders in the Department of Psychological Medicine in the Institute of Psychiatry at King's College London. So that's just a very brief introduction to his title, as you can see here. But I'll pass it to Allan to introduce himself more. A huge thank you to you for joining us tonight. We really do appreciate you joining us here.
Thank you very much, Scott, and thank you for the overview of Mind Medicine Australia. It's always a great pleasure to work with friends and colleagues from Australia. And today I'm going to be talking about the treatment of mood disorders. What might the future hold? Scott's presentation focused very much on psychedelics and perhaps ketamine. I'm going to talk about those at the end of my lecture. But most of the lecture will be contextualizing the bulk of the field and also future developments in all potential areas. And I'll explain as I go along why I've taken that approach. So let's just see. Of course, the slides aren't working. There we go. So these are my disclosures. I'm employed by King's College in London. I'm an honorary consultant in the Maudsley and Bethlehem hospitals. The Bethlehem is the oldest psychiatric hospital in the world. It's about 800 years old, and the Maudsley, of course, is well known throughout Australia. I'm the head of the Mood Disorder Service, National Affective Disorder Service, and so on. My major interests are mood and related disorders, which essentially means all other psychiatric disorders, and the development of new treatments. So I work a lot with industry and do lectures like this. And I've got grant funding from various different agencies. I'm also director of the Centre for Mental Health Research and Innovation, which is in between the Maudsley and King's, which is I guess it would be about 25 million Australian dollars, maybe more, new centre, which James Rucker and I run, and which is fully dedicated towards psychedelic research. And we've been involved in this field for really quite a long time with David Nutt, David Arizzo, and others. Also to say, this is the Maudsley prescribing guidelines that David Taylor, Thomas Barnes, and myself do. Psychedelics aren't in it yet. Producing a new edition, and at some point when they become more widely available, psychedelics, I'm sure, will be in it. Now, mood disorders are split into depressive disorders and bipolar disorders. People often talk about depression as if it's a unitary phenomenon, but of course it's not. Depressive disorders mostly are major depressive disorder. 50% of major depressive disorder is single episode. So there's a very nice study from Baltimore where they followed up first episode depression for about 23 years, about 3,500 patients, and 50% only had one episode, which lasted really just a few months over the course of 23 years. And that's often a surprise to people because the recurrent and persistent depression dominates the field. But it's important to remember, and we always teach our students and residents this, that a first episode of depression has a 50% chance of not recurring, at least over the following 23 years or so. But recurrent depression is very common. It dominates the clinical picture and it poses the biggest part of the healthcare burden. Persistent depressive disorder is essentially a chronic major depressive episode that goes on for 2 years or more, or what used to be called dysthymia. And then there's a ragbag category of subsyndromal, not otherwise specified conditions. Bipolar disorder is the other half of mood disorders. It's also talked about as if it's one thing, but it's a group of different subcategories. Bipolar 1, where there's mania and depression. Bipolar 2, where there's the attenuated form of mania, hypomania, and depression. Mixed states, mixtures of depression and mania, hypomania are common. And then, of course, there's a ragbag category as well, and there's a subsyndromal cyclothymia. It's important to note that there's no hard boundary between depressive disorders and bipolar disorders. People who develop bipolar will have 2/3 will have 2 episodes of depression before mania or hypomania, and depression is the biggest part of the burden imposed by bipolar. So actually, it's really somewhat silly, in my view, to separate these disorders out in terms of clinical provision, because I think if we deal with depression, and particularly treatment-resistant depression, which has higher rates of hidden bipolar in it, we should always be looking at both aspects of mood disorders. The challenge of major depression is really, really considerable. This is a paper by Graham Thornycroft, one of my colleagues. It's published about 7 years ago, but the data is a bit older. And Graham colleagues say that despite being a leading cause of disability, only a small number of patients receive minimally adequate treatment. Minimally adequate treatment essentially means any treatment. So that's 20% in high-income countries like Australia. And in lower middle-income countries, it's 1 in 27. So that's under 4%. So this is really, really shocking. And the barriers to treatment are well known to everyone. Scarce mental health services, which has actually become worse in many places since COVID. A lack of awareness of major depression as treatable. We still see this even with healthcare professionals who say, well, the depression is understandable and therefore it can't be treated, which is a very wrong-headed way to look at it. And also stigma and social exclusion, which unfortunately are as powerful as ever. Now, this is a study we did. You can see my name at the end there. Myself and colleagues from across Europe to really follow up on the Thornycroft study. This is looking at care pathways for people with major depressive disorder. And really, this was an attempt across Europe to try and determine how well we detected and treated depression. You can see that there's colleagues from the UK, Germany, Sweden, and other countries, including Italy, and so on and so forth. And this is the headline result. 52% of depression was detected, which is somewhat better than the Thornycroft result. But of that 52%, only just under 2/3 received any treatment. So again, detection doesn't equal treatment. And of those who were treated, only 1/3 got good follow-up, 1/3 got some follow-up, essentially one further appointment with a healthcare professional, and 1/3 had no follow-up. Now, given that we think that continuity of care and therapeutic relationship is fundamental to good outcomes, this is really, really shocking. Now, in terms of access to specialist care, by which we mean psychiatrists or talking therapies, only 19% had access across Europe. And I think this speaks to the lack of availability of services, but also it speaks to the challenge with talking therapies. I mean, there's a good evidence base for talking therapies, but simply providing talking therapies with therapists as a first-line treatment is not particularly scalable in my view. So thinking about how we best detect depression, the PHQ-9, which was designed by Bob Spitzer, who did DSM-3, is available. The copyright's owned by Pfizer, but that's a way of making it available because someone else would copyright it otherwise. This is an app. You can use it. GPs in the UK use it. It's used in Australia. Of course, it has its critics, but as an initial screen, it's quite reasonable. Do we screen everyone? I think that would be impracticable, but perhaps we should think about screening everyone in particular circumstances, such as after traumatic events or so on. Should we screen high-risk populations? I think we should. There's a couple of factors that determine who's high risk. The personality trait neuroticism, which of course comes from the work of Hans Eysenck in my institution, where he identified the big five, one of which was neuroticism in terms of personality traits. Neuroticism clearly increases the risk of depression and anxiety. Early life adversity. Early life adversity is extremely interesting. There is, of course, animal work from Michael Meany showing the transgenerational effect of early life adversity. And there's good work from my old department in Newcastle showing that early life adversity, when prospectively verified, and there was a study in Newcastle in the 40s where healthcare visitors did a simple scale to measure adversity in the home, and higher rates were associated with the children having much higher rates of depression in adult life. However, our current way of measuring early life adversity, using things like the childhood trauma questionnaire, which is retrospective, doesn't necessarily map onto objective measures. And that's a bit of an open question in the literature. Digital screening, we're hearing an awful lot about this. I'm going to talk about digital approaches because we're going through a real revolution with the application of that. People are talking about using digital screening of speech patterns, texting or activity, and so on and so forth. All of this is at what the psychoanalysts would call the stage of confusion, but I think something will come out of it that may be very helpful. But I think one thing is it will have to be individualized. If you're screening speech, not only are there different languages, but there's different accents and so on and so forth. And lastly, there's the risk of pathologizing everyday experience. Now, I think it's very good that we're seeing much more awareness about mental health, but I think in the UK and perhaps in some other countries, we're seeing perhaps a disproportionate focus on what used to be thought as being normal experience, which has been pathologized. And the sad irony is that people who are talking about their, say, anxiety feelings, which may be part of normal life, are perhaps detracting from those who are really suffering with disorders which impose a great burden. Now, this is one slide about digital. I'm actually just going to a meeting in the United States about digital, and there isn't one particular digital approach. There's many different ones. I think one of the key things about the digital approach is it's potentially scalable. So I think if we look at the delivery, and you can see at the bottom there, mental health apps. Mental health apps fall into two different areas. There's the wellness apps, which are essentially not regulated, and then those that are regulated as medical devices that have to go through the FDA and so on. I think many of the wellness apps are poorly evidenced and poorly evidence-based. I've spoken to some of the developers who tell me that it's obvious that their app is helpful and therefore they don't need to do any research. So I think we'll put those to one side. But I think those which are regulated and examined, I think really do have the potential for delivering therapy. And the therapy may be done in a number of different ways. At the moment, there's smartphone-based CBT and so on. But in the future, we might see virtual reality and augmented reality delivery of therapy. I think this is incredibly exciting. In the Maudsley Hospital, we already have a virtual reality program for treating childhood obsessive compulsive disorder. And I don't really see why we wouldn't have individualized therapy in virtual reality. And that's a very, very exciting prospect. And it'll be interesting to see if that does develop over the next couple of decades. Artificial intelligence, machine learning is revolutionizing our approach to research, prediction, prevention, and diagnosis. The problem with machine learning, it requires really large amounts of data, is that very often the data that we use is from electronic health records, and for psychiatry and psychiatric disorders, that tends to be really quite poor. Digital phenotyping, I've mentioned. I think that may have a role in detection, but there are clearly aspects of the digital ecosystem that might be bad for mental health. There is news in the UK papers about prohibitions in Australia and young people with social media. I certainly share concerns about social media having bad effects on mental health. Now, some people would argue there can be good effects in terms of peer-to-peer support, but I certainly think for the developing game, that's developing young person's brain, that's a potential problem. And also gaming, we see real online gaming disorders. And then moving on to perhaps slightly more at the boundaries, things like emerging neurotechnology. We've just founded Maudsley Neurotechnology to look at applying neurotechnology to psychiatric disorders. This is already being done in neurology and neurosurgery, and I think it's going to come for neuropsychiatric disorders. We already do have some implantable devices, things like vagal nerve stimulation, deep brain stimulation, and so on. Okay, so this is your Australian, New Zealand classification of mood disorders, just to show it's slightly better than the American one I showed, but it's essentially just the same. One of the points, and this is a paper that I did with colleagues in Melbourne, Ian Everall, Mal Hotwood, David Castleman, who was there, Christoph Pantelis and so on, and Sam Lieblich was the leader, is that we talk about depression being one thing, but of course it's not. You can see from the graphic that it's got high heterogeneity. And this leads to low reliability in terms of diagnosis and developing new treatment. And the essential message is that one size does not fit all. I talked briefly about the difference in outcome and trajectory with major depression. This is the paper I was referencing by Eaton, published in the archives. You can see it's from 2008, so there's a possibility of extending this follow-up to 40 years. But this was a population-based cohort in the east coast of the US, a 23-year follow-up of about 3,500 patients. 15% had an unremitting course, 35% had recurrent episodes, but 50% had no future episodes. Now, the median time to recovery was 2 to 3 years, but in those who had a no future episodes, it was a lot shorter. And the risk of recurrence increases after each episode, and only younger age of onset significantly predicted recurrence. DSM, which is known in Australia, it's mostly a US and perhaps Canadian thing. We don't use it in clinical practice very much, but it's very influential in research. DSM introduced specifiers as a way of trying to reduce the heterogeneity of depression. And you can see these are shown here, include severity, remission status, number of episodes, particular times of onset, early, late life, and peripartum, and then the clinical features, which are the specifiers, anxious distress, mixed features, melancholic, and so on and so forth. Now, there was great hopes that this would actually reduce the heterogeneity. Our preliminary work with colleagues in Europe suggests that this is not the case, unfortunately. I mean, this isn't yet a definitive answer, but it's not looking good for the specifiers reducing heterogeneity. Now, what about our current treatments? Scott went through this. Antidepressants have been around since the late 50s. And this is the definitive network meta-analysis by Andrea Cipriani from 2018, published in The Lancet. And you can see there's two measures here: efficacy, which is beating placebo, and acceptability, which is staying in the trial compared to placebo. You can see that every antidepressant is effective, every antidepressant beats placebo, and the vast majority are acceptable in terms of the measure of staying in the study. So I know that people are very pessimistic about antidepressants and so on, but for many people, they are helpful treatments, and we certainly find this in the clinic. But as Scott said, the real problem is that they don't work for everyone. Patient treatment preference is incredibly important, and as yet has been under-researched, in my view. This is nice work from George Papakostas from Massachusetts General. There's also a paper by Koskis that says the same thing. Now, this is not randomized data, but rather looking post hoc at the groups who preferred medication, preferred psychotherapy, preferred the combination, or had no preference. And you can see if you prefer medication, you do best with that, so the combination. If you prefer psychotherapy, you do massively better with psychotherapy than with drugs alone. And then you look at the combination, and if there's no preference, the combination does best. Now, this is almost never examined in studies. And I think for both the talking therapy literature, the device literature, the psychedelic literature, and so on, the patient preference should be examined. And very often, people have preferences for a particular treatment modality which are not necessarily well founded. But I think this is going to be an important factor going forward in the psychedelic research. Now, there's also the difficult to treat depression model. This is a paper by colleagues from the US, UK, Europe, myself. This was really masterminded by John Rush. I think this is a very good description of how we should identify, assess, and manage difficult to treat depression. And the reason that John Rush, who came up initially with treatment-resistant depression, produced this reformulation was because treatment-resistant depression tends to be a dichotomous variable used by regulatory authorities, but this is much more a clinical approach. And here's what difficult to treat depression actually encompasses. The clinician should confirm the psychiatric diagnosis, assess adequacy of prior treatment, look at adherence. Pharmacogenetics are actually very important, and for some people, mainly for metabolic status, how quickly or slowly you metabolize drugs, and therapeutic drug monitoring, assess concurrent psychiatric medication, assess general medical conditions, and environmental stressors. So it's a pretty simple roadmap to what we do in the clinic, but I think it's a very good guide. In terms of the research literature, we talk about inadequate response versus treatment-resistant depression. So if we treat someone with SSRIs or CBT or whatever, we will have some people that respond, but we'll have partial or minimal responders, people with residual symptoms, and this is accompanied with ongoing functional impairment, particularly cognitive impairment. A subset of this is the full treatment-resistant depression, which by convention is failure to respond to adequate doses of two antidepressants for an adequate time and dose. And this is the population that we did the psychedelic studies on. This is the original Thais and Rush model from the 90s. And you can see it's really quite dated now in terms of the treatments. Failure of at least one adequate trial of an major antidepressant would be stage one. Stage two is failure of two, so that's what's become treatment-resistant depression. Thais and Rush said that it had to be a different type of antidepressant, so moving from a tricyclic to a SSRI, for example, or vice versa. But Michael Thais himself did work showing it doesn't need to be two different classes, so that's been dropped. And then we have stage 3, stage 4, and stage 5. You can see monoamine oxidase inhibitors are included there. Now, There is still a use for the old MAOIs. We use them in the clinic for selected patients. There's actually a monoamine oxidase group online led by Dr. Ken Goldman from Queensland, and internationally there's people that contribute. It's interesting that many psychiatrists have lost the skill to use these drugs, but if used carefully, they can be very helpful. We've done the Maudsley staging model, which is a bit more sophisticated than what Thays and Rush did. This involves looking at many other factors, including the duration of the episode, the severity, the number of failed treatments. We've not yet been able to include important factors such as psychosocial stressors, functional impairments, or comorbidities. But my colleague, Professor Tony Clear, has validated the model twice, once in London and once in the Netherlands, showing a significant association of higher scores on the Maudsley staging model with persistence of depression. But we do need more rapid, better treatments. I think to some extent the rapidity of the effect is less important than greater efficacy. So if I had to choose, I would say we want greater remission rates. But of course, we would ideally want something that works within a day or 2 days, and that's perhaps the promise from the new antidepressants like psychedelics. And patients achieving remission in less than 6 weeks typically experience fewer residual symptoms. I think residual symptoms are very important and overlooked. Essentially, you can treat the episode, but the person still has persisting problems with sleep, perhaps low mood, anxiety, cognitive impairment, and these prime for future relapse and are actually very burdensome to the individual. This is TRD. This is what I'm going to focus on now for the next few minutes. Failure of 2 antidepressants. I think actually focusing on this population is a way of reducing the heterogeneity. And I think actually this is much more reasonable than doing new trials of psychedelics in first or second line. That doesn't mean that any new treatment approaches have got to be really only limited to treatment-resistant depression. For current strategies for people with treatment-resistant depression, there's quite a lot that people like myself and my colleagues in Australia do. We optimize treatment, we add another treatment, we dose escalate or we switch. These strategies are common in clinical practice, but evidence supporting their efficacy is limited. And you do get some people better with every step, but it can be a bit of a long, slow slog. And there's things that we do, which are all in the Maudsley guidelines, including combinations. The Newcastle cocktail, in particular, that was done by Donald Eccleston in Newcastle. That's Newcastle in north of England, not Newcastle, New South Wales. It involves lithium, amitriptyline, or an MAOI, and L-tryptophan, and we still use that cocktail. But of course, there's other things coming through, including ketamine. So what are the rapid-acting antidepressants? Well, there's ketamine and S-ketamine. That's probably got the best developed evidence base. What we're calling classical psychedelics to differentiate them from MDMA, because MDMA isn't really a psychedelic. ECT, which is still used. There's a couple of points. Are they rapid? And do we know enough about safety? And I think generally in medicine and psychiatry, there's a tendency to say something's safe too early. I'm a trustee of the charity, the Drug Safety Research Unit, which monitors drug safety, does pharmacovigilance studies, including, for example, the COVID vaccine studies. And I think people should be aware that you never really can say a treatment's 100% safe for everybody. Nothing is. And also you need a huge amount of experience to be able to adequately calibrate the safety risks. So, for example, we think psychedelics are reasonably safe, but remember, we should continue to attend to this. Now, this is the S-ketamine study that I did with colleagues in Germany and others. The reason for showing you S-ketamine is it's a licensed treatment for treatment-resistant depression from the work of Janssen and Johnson & Johnson. There's been a history of looking at ketamine for about 40 years. The first paper was from Iran in the mid-70s. We've looked at this very carefully because it's very interesting because the Iranian doctors were very clever and erudite, and they used ketamine in a way reminiscent of the way we're using psychedelics now. They talked about the interplay between the drug and the setting and the psychological input. So it's a fascinating paper to read. But S-ketamine, which is one of the two enantiomers of ketamine, has been developed by Janssen and has been licensed in Europe and North America for treatment-resistant depression. But this was a follow-up study that we did, published in the New England Journal of Medicine, looking at how it performed against a standard treatment, adding quetiapine to antidepressants for treatment-resistant depression. So it's a big study, over 600 people. One group stayed on their antidepressants and got the S-ketamine. The other group stayed on their antidepressants and got the quetiapine. Here's the results. I'll talk you through this. The primary outcome was 8 weeks, and the dark and the light bars are response and remission. The percentage of patients in response and remission increased in time in both treatment arms, but was higher for patients treated with S-ketamine at all time points. That's interesting, and it's interesting because people talk about ketamine as being something where you have one treatment and you get better, but you can see it builds up over 8 weeks. Moreover, it built up over the following period out to 32 weeks. Now, at every point, S-ketamine beat quetiapine, but quetiapine performed reasonably well. At week 32, a significantly greater percentage of patients were in remission with S-ketamine. Now, one of the interesting things about this data set is compared to work that John Rush did in the US. John Rush did a big study called STAR-D, where people still quote because the treatments didn't perform very well. In STAR-D, many people who did well with drugs very quickly fell back into depression. But we, over the course of the 32 weeks, didn't find that. So we found most people who got well and stayed on treatment stayed well in both arms. This is a similar type of study that we participated in, single dose psilocybin for treatment-resistant episode of major depression. Guy Goodwin, my former boss and head of department in Oxford, was a lead author, and there's people from all over the world, including our group. And this is really the first very good study of psilocybin. Now, a very important point about this is that this is treating psilocybin or any of the psychedelics like any other treatment having to go through the regulatory pathway. So essentially, this is one of the proof of concept trials, and this is now going through what we call the phase 3 trials, the trials that are necessary to get a license. And here you see the data, which I'm sure you've seen before, a single dose. So this is very different from, say, the S-ketamine study. S-ketamine, you got it twice a week for 8 weeks, and then people might go down to once a week. This is one-off dose in a therapeutic setting in our center with the expert psychological support. And you can see it's not placebo controlled because you can't really do that with psychedelics. But there was a dose response with the highest dose, 25 milligrams, doing better than 10 and doing better than the 1. So the 1 was a pseudo placebo. And about 30% of people showed this very significant drop in the Montgomery-Åsberg depression rating scale, and about 2/3 of them maintained it for 12 weeks. So a very, very heartening result. But remember, at the same stage, ketamine and S-ketamine, we were also talking about people having single doses and not needing any others. So bear that in mind as we go through the next few years and look at the data with psilocybin. So what about our current treatment strategies for people with depression? So this is all about looking at in the round. This is our Maudsley treatment pathway. We think it's very important for screening for depression and diagnosing. Everyone who goes to the GP should perhaps be screened, and high-risk groups should be screened. Then people should be treated either with CBT or SSRIs. In England, not in Scotland or Wales and Northern Ireland, but in England, we have immediate access to psychological treatments, which costs billions of Australian dollars, and people can walk in and get CBT for depression or anxiety, but there's still a lack of access. Again, speaks to the need for having something which is more scalable for psychological treatment. Thereafter, if people don't respond and do well, It's not a linear pathway. It's a bit of a menu of options for things like switching, combining, augmenting. And this is, I think, initially where psychedelics will fit in. And then we go to inadequate response and we have other things. If people have, in their first episode and they get well, they should be maintained for 6 or 9 months or for 2 years if they're recurrent. But I think this will change. I mean, we just don't know what's going to happen in the future with things like psychedelics. If they do come in and are viable treatments which are licensed, then people may have top-ups. We can talk about the issue of microdosing, but I'm somewhat skeptical about that being therapeutic for depression and anxiety, although some people are very interestingly talking about microdosing being beneficial for neurodegenerative disorders. So just to say that we think there should be centers of excellence. This is our Maudsley Advanced Treatment Service, which we set up before COVID. We don't yet give psychedelics here. We just give psychedelics in our psychedelic center for research. But at some point, we will be giving psychedelic-assisted treatments here. And you can see that we even get visits from Australian luminaries, such as my dear friend, Professor Michael Burke, who visited us just before COVID and actually spent a few months in my center. I'll stop there. Thank you for your attention and look forward to taking any questions.
Thank you. Thanks so much, Alan. And so if anyone does have questions, please do put them into the chat, and then I can pass them on. And while we wait, but maybe for anyone to put them in, Alan, I have one because there was one slide in particular there that I thought was really fascinating, which was on patient preference.
Yes.
That's not something I've seen before. I thought that was like very interesting, and I'm curious to know if you have any just additional thoughts on perhaps where that might go with research, because I think that to me like struck me very strongly as something that I haven't seen any research into before. That was like super interesting.
Well, I mean, my colleagues in psychological research, people like Professor Pim Kuipers, who we've been doing some work with recently, we're all very interested in this because we think there's a couple of reasons. One is that it can powerfully influence research results. So, you know, if you're very keen on getting the new psychotherapy, but it's not available except in a trial, and then you get randomized to either get the new psychotherapy or not get it, then I think that's going to inflate the difference between the two groups. And I think this is an issue for psychedelics as well, because people are so sort of keen to get it. So I think we should be measuring it in research. We should be aware of it. I think there's perhaps been a tendency in some research to be aware of it, but not explicitly explore it, which is, you know, not really what we should be doing. But also clinically, we should be talking to patients about what they want, and you know why they want it. So very often we have patients who say that they're not willing to have a particular type of treatment, for example, lithium, which we use a lot, and because it's a stigmatized drug and so on. But of course, lithium for many people is a game changer. So it's important both clinically and in research.
Great, thank you. So I might grab one question here that's coming from Jacqueline in the chat. I'd love to hear your thoughts on whether trauma underlies depression. I wonder if psychedelics tap into unresolved trauma rather than treating depression per se.
I don't think trauma causes depression because people can necessarily, because people get depression without trauma. So that's the first point. What I think trauma does, and of course trauma needs to be defined, is it makes everything worse and more difficult, especially treatment response. Generally, we think of trauma as early life adversity. There is, of course, you know, acute trauma, and there's great work done in London a generation ago showing that stressful life events trigger off depression, but you don't necessarily need to have a stressful life event to get depressed. But early life trauma does clearly make the outcome of whatever psychiatric disorder you get in adulthood worse. Response to treatment is lower. The likelihood of getting the disorder is higher. So the Newcastle 1000 study I talked about, where 1,000 kids were born in Newcastle in 1947, they had their home adversity measured by health visitors on a 6-point scale, and then they were followed up when they were 35. If they were at the top of the scale, they had 5 times the rates of depression at the bottom, but there was still some depression with no adversity. So we are doing a lot of active research in this. We think that the trauma which is most powerfully bad is emotional abuse and emotional neglect, which makes sense. We think that if you don't have that, you can compensate for lots of other types of trauma. But a methodological issue is that the childhood trauma questionnaire doesn't appear to be very good for actually measuring trauma. There's really nice papers by Professor Andrea Danesi, a colleague of mine at the Institute, who compared childhood trauma as measured by the CTQ, which is a questionnaire that you ask adults, so it's retrospective, compared with digging down and getting objective measures at the time, such as court records, and there wasn't a great correlation between the two. So I think there's a methodological problem, but undoubtedly early life trauma is one of the huge issues. And it also tends to interact with genetics. People think there's trauma or genetics, but Randy Katz, who worked in the Institute a few decades ago, showed that environmental and genetic risk factors tend to go together rather than be separate and independent.
Amazing, thank you. Another question that's come here from Angus. I'm sorry, Angus, if I've misinterpreted it, but do you think focusing on microdosing may enable better access for patients, or is a macrodose showing more promise?
I think the macrodose is showing promise at the moment. I think there's an argument that microdosing may just be a placebo effect. I think there's a huge debate and scientific uncertainty about what's really going on with psychedelics. So, there are some people like Professor Stephen Stahl, right, American psychiatrist, who says the psychedelic effect is just a side effect. Really it's doing something in the brain that's fixing depression, and the psychedelic effect is an epiphenomenon. I mean, that's a pretty extreme view that not much people go into. The other extreme, some people are saying, well, it's all about the psychotherapy, and the drug is somehow enabling the psychotherapy. What we've found in our preliminary analysis that Guy did, we published a paper on this, is that the antidepressant response is very linked to the psychedelic experience. So it's very linked to the psychedelic experience, not necessarily to any therapist parameters, although we think the therapists are very important for safety and integration and so on. But the psychedelic effect seems to be crucial. Now, microdosing, as I understand it, you don't really get the psychedelic effects. But there are colleagues looking at this in neurodegeneration, where psychedelics may be important. Now, by neurodegeneration, I mean disorders like Parkinson's and Alzheimer's and so on. And the psychedelics do seem in animal work to promote neurotrophic changes that may be beneficial. So it may be paradoxically that there's different areas where you use the macrodosing for things like depression and the microdosing for things like Parkinson's and so on in the future. I mean, we don't know. We just need lots of trials to try and work all this out.
Mm-hmm. And can I actually just piggyback with one more question with that? With that data that you're saying that's suggesting that it's the psychedelic experience primarily, and then the therapy is supportive of safety, is that specific to classic psychedelics, or is that also relevant to like MDMA as well, or do we not
No,
know?
that's just an analysis from the New England trial that I showed you.
That's just looking at that psilocybin trial. Gotcha.
Just looking at that one psilocybin trial, and that I think was published this year, and I'm on that paper. But of course, remember, just like one swallow doesn't make a summer, one trial doesn't necessarily establish things. Maybe totally different for MDMA.
Mm-hmm.
We've done the MDMA trials as well, and we think it's really quite different from psilocybin. So,
Mm-hmm. And is that in terms of the the mechanisms of how it's working, or can you just?
Oh, both, both. I mean, I think the patient experience and the mechanisms are both very
Mhm,
different.
mhm. Um, Great. I might also just ask if anyone else has any other questions that they'd like to throw into the chat. Um, and then one more actually that I'd also like to jump in at, because I have questions if there's others that aren't coming through. But
Yeah.
is you made the comment about that early research from Iran, I think it was, that was looking at ketamine
Yes.
and looking at the set and setting and perhaps the interaction with the psychotherapy. I'm curious to know where with research currently, are you doing more, involved in more that is involving that, I guess, more of that look of the psychotherapy and the set and setting with ketamine in addition?
Well, I think that's a great question because I think we tend to have two different approaches to it. We tend to have the psychedelic approach, and then there's the ketamine approach. And I always say that the ketamine approach seems almost to be like a trip to the dentist,
Hmm.
whereas the psychedelic approach is like a trip to some new age ashram. And it'd be interesting to examine, to cross over and to see what factors were particularly important. But I think one thing, no, they're not near offering they're not near offering psychedelic assisted therapy in the UK at the moment, although it is available, I think, in the Netherlands. But the phase 3 trials are coming, so it may happen before we know it. Anyway, so I think the great thing about the psychedelic whole approach and literature is it's looking at both the psychological approach and the pharmacological approach. And we've lost that really in a lot of other areas of research. And that would inform an approach for these disorders overall, because things like patient preference, interaction with the therapist, these are extremely important. We need to look at the set, excuse me, in the setting for all therapeutic research, in my view.
Hmm. Yeah, this makes a lot of sense. I think this is a reflection that I've had that it's like putting psychotherapy and pharmacotherapy and trying to find a way to integrate the two of them makes a lot of sense, which in some ways is a part of what's happening with these psychedelic protocols.
So there's a question: which psychedelic treatment is the best outcome? Well, we simply don't know. At the moment, the best study is the psilocybin study. There are other psychedelics which are far briefer in onset, in duration. DMT, 5-MeO DMT. We've done work with that. Um, Realistically, what we are going to see is each psychedelic establishing efficacy, and then hopefully there will be a comparative trials. Um, Next question: what's the success of amitriptyline and lithium? Well, I mean, basically boosting 5-HT. So you boost 5-HT with the antidepressant with lithium, and then very often what makes the difference is adding in L-tryptophan, and so it's pushing the system as hard as you can. It was synthetic psilocybin. Yeah, synthetic psilocybin in the New England Journal study. Yeah, we're aware of the Israeli company, and I think there's going to be lots of compounds coming out. Okay.
I've got a final question, if I may.
Yes.
Can one use MDMA and also psilocybin interchangeably to treat, say, depression?
Well, that's the type of research that will need to be done, is about a combination of treatments. So, there's, I mean, at the moment, no one's doing that because they're trying to establish efficacy per se.
Yes.
I think the next step, Allan, is to look at, multiple dosing. If you don't respond to the first dose of psilocybin, perhaps you need 2 or 3 more. If you do respond and lose it, what happens if you get another treatment session, and so on and so forth. But all of that will eventually lead to looking at combination studies.
So how is it that MDMA has been the go-to psychedelic for PTSD and psilocybin has been the go-to medicine to treat treatment-resistant depression?
Well, I think that's an artifact of history, but we've done the study with psilocybin with PTSD, and psilocybin seems to us to be very effective for PTSD, incredibly
As
effective,
well.
actually.
Amazing.
Yeah, absolutely. I mean, again, be careful about assuming too much from the evidence, but certainly, we were myself and the researchers were struck with the efficacy.
Amazing. I guess these are all the interesting questions we'll learn more about over the coming years as we continue to research.
Right. Okay. Well, thank you very much. I'm afraid I've got to run off to go to the airport to go to my digital meeting.
Wonderful. So thank you so much,
Oh,
Allan. We appreciate your time.
Just to give one last advert, we're having the CINP, which is the International College of Neuropsychopharmacology in Melbourne, in 15th of June next year. So it's a big meeting, and there'll be some work about psychedelics being presented.
Fantastic. Thanks so much, Allan, and hopefully maybe we'll get a chance to connect while you're in Australia.
All right. Thanks. Nice to meet you.
Thanks so
Thank
much.
you, everyone.
Have a
Bye.
good day. Thank you, everybody. Good night.